alternative position is actually the same thing that Michael was showing on here with like the arm going down. That is, it goes like, again, hand in hand with his assessment. At least I can speak for myself. I usually measure them, and then like, this is usually one of my last ones that I happen to do, like from here or here. And I usually, that goes right into my intervention almost. So I don't have to get them out of that position. I don't know how your flow works.
Same.
Yeah. And so for this one, you could start in this position because it's a little less for the advantageous to the supraclavicular bursa if we're thinking about impingement. So you can start in this position and do the same thing. I prefer them to try to get as much horizontal adduction as tolerable. The problem is with this is the higher you go up in shoulder flexion, the more discomfort, like the more like impingement pains they have, the more chance they have their shoulder to escape. So if possible, I try to get them in the sideline position. But I recognize the fact that like, you know, people work and you can do this at an office table, at an office desk. So I try to limit the barriers of like where they're doing it. So sometimes I'll have them start with their elbow on like a table this high, and like if you're here, you're not gonna feel much. But I would have them go over like they're gonna pull the sword out and do it in this position over here. So the only thing that I have to cue them is to pull the scap and hold the scap. And then that kind of like, also just a disclaimer for this. This is just glenohumeral joint range of motion. We simultaneously we're working on a scap stabilization program, so they should know how to do this by this time. All right, and again, like I know we're like for this one, it's specifically limited linear motion for like horizontal adduction. So they're already like up top there for limited internal rotation. You can do these. It's kind of the same, but I'm more working in this position first, and then the progression for linear motion is going across. Next.
So as opposed to like the classic, like you're stretching there for 30 seconds or whatever it may be, you're having them push into external rotation for 10 seconds, and then relax, bring it back in.
Actively. Yeah.
And then do they hold it there actively for a few seconds
Yep.
before they start pushing?
The 10 seconds. So
Okay.
here, I'm just gonna do it up here. Actually appreciate this. I'm holding it for a minute, pushing up for 10 seconds, and then I'm actively trying to bring it down, and I'm gonna meet my hand where that position is, and I'm still actively pushing down. It doesn't look like I am, but I'm trying to get it farther. And then after 10 seconds, I just relax my hand on top of this one, and I'm hanging out here for a couple seconds, like basically to recharge. And then after 10 seconds, like I usually just say, we'll just do 10-second intervals for everything, just to make life easy for them.
Sure.
So I do 10 seconds, 10 seconds, rest for 10 seconds, 10 seconds, 10 seconds, rest for 10 seconds, and I do that 3 times, yeah. Yep.
So you're not doing external and internal rotation like you were in the sideline position?
I'm still doing, like I'm actively.
Resisted?
No, because I wasn't, the internal rotation in the sideline position, it wasn't resisted, the dowel was in the hand, so it looked like I was resisting.
Oh.
Maybe that was, yeah, so I'm actively moving the dowel farther down.
Okay,
And
so
I'm
that's
just.
the internal rotation part is the active part.
Yes.
The only resisted part is the external.
Is the external rotation. So like, thank you for, so if we're improving internal rotation range of motion, we need to stretch out the external rotators, and whatever muscle you're trying to improve, or improve the muscle length, that's the contraction muscle that we're like pushing into.
But you're not doing both.
I'm not doing both.
Somehow
Yeah.
I thought when you're on your sideline, just the one you just did just before, somehow I thought you were doing both.
Oh no, yeah, because like, the hard part is like, that was a pretty, like you're really stiff, but you definitely feel it in that position, so you can't appreciate as much movement. That's why like the sideline one, it's like really hard to, like if they're laying on the shoulder, it's my preferred place, because the shoulder, like you literally are getting like the end range strength that we're looking for. And so, yeah, I guess to go to your question on the traditional sleeper stretch, it's not just holding here. You know, it's not wrong to have them hold here because you are like improving like our goal of mobility. The thing about this is we're setting ourselves up for the next phase of rehab when we're working on motor control. And so by adding these little impulses of muscle activation, they're able to actually gain more awareness of like what their rotator cuff is. And then the other thing is that we're starting the tendon like healing process. So wasn't, you know, like the way that the tendons, like to help promote healing of the tendon and help promote tendon resiliency, the tendon needs to be in a lengthened position. And so that means that the external rotators, like the tendon like most lengthened position is going to be internal rotation and horizontal abduction. So that's why we're working into these positions. Yes.
This I guess more of like a theoretical question, but like in terms of like tendon loading principles, like how much change you're actually affecting on like the rotator cuff tendons doing isometrics in this way, or is it more like an activation standpoint that you're trying to get?
Yeah.
Or like more that mobility part.
So we are creating tendon changes,
Yeah.
and I encourage everyone to, if you haven't already, like look at Keith Barr's work. He's at UC this, right?
That's correct.
Yeah, and he's like his tendon, like I think he's just doing incredible work on like tendon morphology. And so I would, I don't know, would you recommend anyone else? He's got it.
So yeah, I mean it's not just him, right? He's just the head of the lab there, and if I was to expand on what JC meant as incredible, is that they're really mechanistic studies, and they're looking at the tendon property changes, and not just tendon, but connective tissue changes. And if I was to further elaborate on that, so he takes what is the lab-based studies and makes it very tangible for the implications that it has for rehab. So keeping with that same theme of the recommendations that come out of UC Davis, so he does recommend like the 10-second holds for healthy tendons. Having explored the isometric realm and some of the other things that he's expanded on for pathological tendons, that he would suggest, or the evidence suggests, I would put it that way, is that when you're doing submaximal resistance, which that's what this is, and you have heterogeneity within the tendon itself, which we do because it's been repaired, and we're working with injured populations, that I'll use my 3 fingers. Say my middle finger is the compromised portion of the tendon, that I need to actually hold it for close to 30 or 45 seconds. And why is that the case? Because my ring finger and my index finger bear the load initially. I talked about the stress shielding effect yesterday. After about 30 to 40 seconds, you get a stress relaxation in these 2 fingers, the non-middle fingers. When that stress relaxation occurs, the force has the opportunity to penetrate what is the injured portion of the tendon. You, at 3 minutes of an isometric, you get about 80% relaxation, but you get a disproportionate amount of that in the first 45 seconds. So your essentially your return on investment after 45 seconds is otherwise marginal. And so we're trying to work people up to what is the optimal training dosage for their connective tissue. What is that? That is high intensities, greater than 70% 1RM, better than that is even 80%. As JC mentioned, training it at length, right? Why is that the case? I'm just gonna expand on that a little bit. So I'll use my bicep again, I just think it's an easy example. If I contract my bicep here, the force concentration within my contractile tissue is concentrated within the muscle belly. When I contract my bicep against resistance here, the force distributes to more of the poles. What are the poles? The poles are what we call the tendon. Yesterday I also spoke about the intramuscular tendons, right? So there's multiple tendons within the muscle, but if our goal is what the reductionist approach calls your tendon, then you want to do it at length, You want to do it for high intensities, and you want to do it for about 10 seconds. But tendons can't tolerate this right out of the gate. So we do sub-maximal. We're close to end range, or as close as the tendon can get. We're holding it for sub 70% 1 RM or 1 rep max, or if you want to go RPE, fine. And we're doing so for that 30 to 45 seconds. The other principle would be the dose response. So tendons get what they call signal saturation between 10 and 15 minutes. You can continue to load the tendon, and they can continue to do exercises beyond that, and they may get other adaptations. But the actual fibroblast and the enzymatic reactions that help for collagen deposition stop reacting after about 10 to 15 minutes of loading, and they become responsive again at about 6 hours post. And they know this because they take ACL grafts off all the ACLs that occur up in Tahoe, and they put them on mechanical transducers, and they load it continuously, and looking at the time-lapse response of the enzymatic reactions for these collagen fibers, right? And the continuous passive motion machine was previously a discussion, right? But again, so 15 minutes, 10 to 15 minutes, every 6 hours, sub-maximal, right? And 30 to 45 seconds would be ideal. So that was a little bit more of an elongated answer, but I feel like rather than just giving you part snippets,
Right.
trying to give you the whole dose response relationship of what we're trying to change is really important, and expanding on the rationale beyond just the tangible application that JC described.
Yeah, and we'll keep reiterating the doses as we go along with these. So we're just trying to gain that capacity first. I would say that ideally the strength area is where that's where we have to get up into those like 3 minutes of time under tension, like up to try to get to 5, but yeah. All right, good with the sleeper